morning, listeners. Welcome to the Chamber Connections, connecting business with the community. Today, we have the pleasure of sitting down with Dr. Gary Lai, Chief of Emergency Medicine in the Emergency Department with Broward Health. Welcome to the podcast today, Doctor.
Thank you very much, Charinus, and I'm thankful to be on here and speak to your listeners.
Well, today we are truly excited as we take part of the podcast segment of Workplace 365, and we have a series of questions that we'd like to ask you, especially since you are working in the emergency room and you see so many different people coming in for different cases. So we'll just jump on in. What are some of the symptoms that people may see that may be related to cardiac arrest?
Right. So I think it can't be, overstated enough just to kind of educate everyone out there. The most common symptoms that you always hear about is like an elephant pressure sensation, crushing pain on the chest. Sometimes you get some like associated arm numbness, sweating, shorter breath. You might feel some palpitations or dizzy. I mean, those are all like pretty much like kind of like textbook symptoms of a potential cardiac event. But it's very important also to know that a lot of times you'll have more subtle symptoms that are also very important that you have to look out for. And also, especially in females, because it's been notorious that, acute coronary syndrome or what we call myocardial infarction, like heart attacks, a lot of times females come in with much more subtle complaints.
Correct.
And sometimes it could just be fatigue. It could be some shortness of breath with exertion, just not feeling well, some nausea, vomiting. I remember cases throughout my career. Sometimes people just come in complaining of, I got this bad numbness sensation in my arms, like it's pins and needles in both arms. Mm-hmm. I just feel right. Sometimes there's that feeling of impending doom. So all of those symptoms, really should prompt someone to go to the emergency room. I wouldn't really recommend that to go to the urgent care, just because, they have limited testing capabilities when it comes to something like that, potentially life-threatening.
And I'm glad you touched on the fact that women, and it is a different population, on how they experience cardiac arrest and some of the other cardiac related symptoms, and being able to identify them in our loved ones is also so important because we have our children, we have our parents, we have to really worry about it in a community setting. And I know now in the workforce, a lot of people are in the office, colleague may be experiencing some of these type symptoms. The biggest thing when it comes to cardiac, would you say people are going more to the ER, or do you think people sometimes opt to go to urgent care?
I believe most people still know to go to the emergency room. I mean, unless they're having more like kind of atypical presentations, such as, maybe just like the fatigue or little shorter breath, or a lot of times, unfortunately, people think it's just gas, they'll just kind of put it off to like, I feel like this is indigestion. Yeah. And in the emergency room, that's something that, we always, when you listen to that, we're always got to think worst first. And, gas indigestion is a diagnosis of exclusion once you kind of exclude all the more, life-threatening conditions. And also there's different subsets of patients, like also including diabetics who sometimes never even have chest pain. They're notorious for having what's called silent heart attacks. They may never even feel chest pain. Or sometimes if someone's having a heart attack involving the inferior wall of the heart, they may just come in complaining of upper abdominal discomfort. So you have to kind of take everything in context, and we risk stratify patients based upon their comorbidities, meaning like their past medical history, those greater than 50, 55, history of high blood pressure, diabetes, high cholesterol, family history is very important, smoking history is very important. Any kind of illicit drug use is very important. So everything like that, it's really, if you're having any kind of serious symptoms like that, I really suggest you go to the emergency room and as soon as possible, and definitely, there's a choice between two different facilities, and one's and they're almost just as close, you definitely want to go to one that has a cardiac catheterization lab.
No, that's definitely great advice, and thank you, because I think sometimes people, you're right. Oh, it's gas. Oh, I can drink a ginger ale or have some Tums. We always want to self-diagnose a lot of times in this today's time in our society. What are some of the subtle symptoms when it comes to neuro-related issues or possible complications?
Yes. So definitely stroke is another big emergency condition that we treat. And another one, again, like time is of the essence, in heart attacks, time is muscle. In stroke, time is brain. So, the most common symptoms, like there's some mnemonics out there, like people may have heard of FAST, like FAST, the F standing for facial droop, the A for having like an arm drift. If you put both your hands out in front of you and close your eyes, one of the arms may drift downwards. The S is for speech, any kind of speech disturbance, usually slurred speech or sometimes not even able to speak. And then T stands for timing, because, most strokes, the majority of them, about 85%, are what's called ischemic strokes. And that's when there's a blood vessel that's blocked with a little clot. And then that's what's preventing the blood flow and oxygen going to that brain. And then that's when you develop symptoms. And it's in those cases, majority of cases, where if it is caught in time, there's a medicine called TPA that we use in the emergency departments. And basically it tries to the IV, and it needs to be given, as soon as possible, but, less than 4.5 hours is the biggest time window that we have. And then if you're having a really advanced stroke where you're having very severe deficits, and then there's a possibility of what we call a LVO, which is a large vessel occlusion, like one of the major arteries, be it maybe carotid or one of the cerebral arteries that is blocked. And in those cases, we give the TPA, but we also transfer the patient for what's called mechanical thrombectomy. They get intervention where the specialist can actually go in there with the catheter and get to the clot and try to clear the clot by, breaking it up and sucking it out.
And it's definitely, we know, going to the emergency room on that one for sure is where one would definitely want to be in order to have their diagnosis done immediately by a physician, correct?
Correct. And unfortunately, I have seen many delays in those instances, because this a lot of times people, especially during COVID pandemic, like peak times, everyone was afraid to come in, heart attack, stroke, and we would see patients come in like, over 24 hours, sometimes 2-3 days of symptoms. And that's at that point, a lot of times there's not much that we can do. And, recovery may be very limited. And then there's also some subtleties as well, in those what's called having posterior circulation strokes. Those may present atypically. And a lot of times patients can come in complaining of just feeling dizzy, off balance. They may have some visual disturbances like double vision or blurred vision, or you may actually even notice like their eyes are not moving properly in certain directions. In those cases, it could affect like the cerebellum, other posterior circulation structures. And those a lot of times are even harder to diagnose, but it's something high on our priority list when we're considering differentials, because a lot of times patients come in with a complaint of vertigo, where you feel all of a sudden suddenly dizzy, you can have nausea, vomiting, but it's very, you have to be acutely trained and know how to kind of differentiate the two. And that could be the big deal of proper diagnosis and prompt treatment, and then hopefully, a good recovery.
Yeah. And I'm glad you touched on the fact that people, yes, you're correct. During the pandemic, I did hear a lot of people say, well, I don't want to go to the hospital. They wanted to, kind of wait it out. And I think you're right. The longer those type of situations go, the worse one can become. And I'm thinking about abdominal pain and high risk features. What else would be some other things that would fall under, going to the emergency room for abdominal pain and getting that treatment in place?
Definitely. So, abdominal pain is a very common complaint that presents to the emergency room. You can get the run of the mill, maybe some vomiting, diarrhea, maybe a little bit of gastroenteritis, but, important features to look out for. If you do have a fever with this abdominal pain, that kind of increases the risk of something serious going on. If you have severe pain, even maybe what's called rebound, like if you gently push on your belly and kind of let go, if you have this, what we call peritoneal signs, that's, clues that something serious could be going on, possibly a perforation. If you're just driving in your car and every little bump is making this pain excruciating, I really suggest you would go to the emergency room. Urgent cares are very good for different complaints. They have, they can do labs, they can do EKGs, they can do simple x-rays. But when it comes to, abdominal pain complaints, and when you're worried about something like appendicitis or diverticulitis or gallbladder cholecystitis, different things like that, or a bowel obstruction, then that's when we usually need to get further advanced imaging like CAT scan or ultrasound, and those aren't usually routinely available at the urgent care center. So, fever, severe pain, maybe vomiting with it. And then you got to think about your potential like pregnant patients. If you're having pain and you're pregnant early on in pregnancy, maybe you've never had an ultrasound yet. We always think about, make sure this is not an ectopic pregnancy, like a pregnancy in a tube that could be something life threatening. So all those different things to kind of think about. And that might drive you kind of more towards the ER if you have any of those signs or symptoms.
Dr. Lai, I needed you a few years ago when I ended up with appendicitis, and I just thought I just ate something that just didn't agree with me. And I went to see my physician, and he quickly rushed me to the hospital. So you are right. Yeah, you are 100% right. We think, oh, it's only this. Oh, it's only that. And, it's timing, and every minute that was going by, he was like, we have to have surgery stat. So I wish I had known to listen to this type of conversation before, because it's so important. Again, even at work, your colleague, your family, you just never know when this will, when it will show up.
Yes, absolutely, man. I'm glad you got the care that you needed timely.
Thank you. Let's talk about traumatic injuries and high risk features. What are some of the things that you all are seeing in the emergency rooms?
For sure. So, we see, a broad spectrum. You can get like simple ankle sprains. You can get, fractured dislocations of joints. You can get open joints where they fracture and the bone is protruding from the skin. Different high risk features that we think about when it comes to trauma. You have to think about, patient's age. Are they, is this an elderly person? Was there any kind of head injury? Was there any loss of consciousness? Are they on any blood thinners? So, aspirin is one, but then we're talking about the more potent blood thinners in addition. Sometimes patients are on what's called anticoagulation, which could be like, Xarelto, like Eliquis, Coumadin, Plavix, some of those type of medications that they may take for heart conditions or previous blood clots or for stroke. Any kind of trauma and a patient's anticoagulated or other blood thinners, obviously can kind of increase the complexity and, the morbidity and mortality. So if you're having like maybe like a simple ankle sprain, foot sprain, something like that, urgent care can easily kind of treat that. You have something like, say you have a more complex laceration. Simple lacerations can be taken care of in the urgent care as well. as long as, they're not on blood thinners and stuff like that. But more complex lacerations include, like, if you can visibly see like a tendon injury, if you can see bone, if you have limited range of motion of your fingers, from where the cut may be, all those kind of prompt more specialty care. And, a lot of emergency rooms may have specialists on call, such as plastic surgery, orthopedic surgery, hand surgery. Each department's kind of different. They have their own different on-call specialists, but that kind of provides a little bit of advantage there. And then if there was a truly, severe injury, maybe a head injury with an internal bleeding, that's something, obviously we need to diagnose with a CAT scan. But then there's, certain reversal agents that we can give in the emergency room to try to help, reverse that blood thinner agent to, decrease the amount of continued bleeding. There may be need for airway control if someone becomes confused after the head injury. Sometimes we need to protect the airway by, sedating the patient and putting a breathing tube down for them as well. So, trauma is a big thing. Always looking for complexities, tendon injury, bone involvement, already on blood thinners, was there loss of consciousness, all things like that. If someone had a bad injury to their ribs, and now they can't breathe or it hurts to take a deep breath, then you may be worried about something like, could there be a collapsed lung? Could there be a liver or splenic injury from a broken rib? And all those require, sometimes advanced imaging, as well as there's like a collapsed lung or something like that. You may need a chest tube to decompress that. So all those different things to kind of think about.
You gave us a lot to think about. And I think it's so important for everyone, hopefully folks that are listening, that you never know when you may use or have to, put some of this into play, far as, making that assessment. Do I go to the emergency room or do I go to urgent care? Last question I have for you, and it's a hot topic I know we've been talking about for 2 years. COVID positive signs or symptoms. At what point should one consider urgent care versus, inpatient treatment in the hospital?
Yes, definitely. It's been a tough years here, to say the least, but fortunately, Florida, our South Florida peak kind of happened a few weeks back. And at that point, it was just, pandemonium, and just it was unreal, the surge of patients that we were getting. Limited spaces to treat patients. Lots of patients were waiting in the waiting room for extended periods of time. Definitely made things difficult. But, with the presence of a lot of like outpatient testing centers, if patients were just coming in, just trying to get a simple yes or no, a simple test, at that point, we were trying to ask those patients to kind of go to a testing center if they were not having any kind of serious symptoms, because, with such large amount of patients and, having to test every patient that gets admitted to the hospital, patient that's going to get a procedure, you could definitely, see like our resources were being taxed and limited at a certain time. But yeah, definitely those that are feeling short of breath, that usually comes as a little, late finding with the patient too. Most of the time, like, they start coughing real bad, and they can't even speak in complete sentences. And when you're having coughing fits in between speaking sentences, that's kind of like a clue, from all the patients that I've seen, that it's a little bit of a clue that there's probably some lung pulmonary involvement already. And when we take a look at what's called the oxygen saturation rate, what's your oxygen level without any supplemental oxygen? Okay. Normal person, non-smoker, you're talking about, you should be, above 96%, 96 to 100%. We see COVID patients, a lot of times they may come in and they may have an oxygen saturation of like 94%. But what's key is doing what's called an exertional saturation. So, a lot of patients that I saw, actually went out and bought their own little pulse oximeter.
Wow.
You can get them on Amazon for like maybe $20, and they would have it on their finger. They would monitor themselves, their oxygen levels, and be like, "Oh yeah, at home I went down to like 88% or something." So that's what's key. Like if you're sitting in a waiting room for like an hour, and then someone checks your oxygen level, you've been resting there for an hour. It may be 94, 96. It might not look so bad, but if I get the patient and I walk them around the room a few times and they're getting short of breath, then I'll check it. A lot of times they'll drop into the 80s, and that's when we know it's very serious, when it's less than 93%. And that's when it usually requires inpatient treatment. So, those with COVID, a lot of times the shortness of breath doesn't really kick into like second week. That was like the first year. Then we noticed Delta variant that, wow, patients were getting shorter breath quicker than that second week. So monitor the symptoms, maybe even get a little pulse oximeter, monitor your oxygen levels, and then utilize the resources available to you. There's the monoclonal antibody that's out there.
Yes.
There's been like, I think C.B. Smith Park in Broward County was doing that, 7 days a week. Like it was like 9 to 5.
Yes.
And we've seen a lot of good success with the monoclonal antibodies. At Broward Health, we would schedule patients to get the IV infusion. I know at C.B. Smith, it was like 4 injections. But still, nonetheless, it's been shown to help a lot of like high risk patients from preventing to advance and getting sicker and requiring hospitalization. So it was like over 80% from the studies that they've tested. It's not FDA approved, but it has the emergency use authorization. And then they also expanded it not too long ago that if someone was exposed to a known COVID-19 patient recently and they're at high risk for developing, infection, that you can also be eligible for the monoclonal antibody. So I think that I definitely, with the vaccinations out there, with so much population that's already been infected already, hopefully these numbers are just we're not going to get a huge surge again, come this winter. But definitely everyone's got to keep the PPE, keep the social distancing, wear your masks. And, we're trying to do the same and keep everything safe in the ER and hospitals as well.
Dr. Lai, you have just given us a lot of amazing resources, and I truly hope our listeners are able to put some of this into play. And you're right, as we head into winter and we start our family gatherings, we want to make sure that that we're safe and that we are, wearing our masks, practicing social distancing, and that we continue to put our loved ones and keep them safe and put ourselves in the right situation. That's all we have for today, but I have to tell you, you have just blown me away with everything that you just shared. It's just got me rethinking as we move forward, all the things that we have to continue to do, because we still have work to do.
Oh, thank you. I appreciate you having me on here. And definitely, I think it's very important to kind of get the word out, let everyone know, hey, if I'm experiencing any of these symptoms, definitely don't kind of delay it and try to get the medical care as soon as possible.
Sounds good. Dr. Lai can be reached through the Broward Health Medical System if anyone wants to follow up with him. Thank you again today for Dr. Lai for joining us. And I am Charinus Davis signing off for Chamber Connects.